It's been a long day. We've got one final panel. We're going to talk about patient matching and the challenges that come with that, a very important part of interoperability, making sure that as we're exchanging information, we're doing so about the right person. We're going to hear from other states as well. We'll hear from New Jersey and Utah, as well as Michigan. And moderating our final panel today is Greg Church, who is president of 4Medica. Greg joined 4Medica in 2009 as a senior marketing executive. He helped 4Medica expand its interoperability customer base and further defined new product lines in the identity matching, clinical data exchange, and revenue cycle management service areas. Today, he's president of the company. Ladies and gentlemen, Greg Church.
Good afternoon. I know we're the last group here to present, and I know there are drinks waiting after this, so we're gonna keep this moving. So very excited to be here. We've got some great panelists up here. We've got Teresa Rivera. She's CEO of MiHIN, that's the Utah Health Information Network. James Nolan is product manager for MiHIN. And we've got John Novak, who is Senior Director of Technology and Innovation. Okay. So what we feel in the patient matching space, there's a really big need here. We talked about interoperability today, and there's a lot of great initiatives going on across the country, and we know we need to move data, but we go to bed at night worried about, are we really moving the right data on the right patient at the right time? And so patient matching to us is, it's very important as a company that's in this space. So we wanted to take some time today, and if you kind of profile these three different networks that are up here, Utah represented about 3.2 million identities, Michigan around 10 million, New Jersey 9 million. That's 22.2 million identities represented up here, or 7% of the US population. So they're doing some great things in their networks, and we wanted to touch on some of the things that are working well. I mean, in lieu of not having a national identifier as a country, and it doesn't seem like it's going to happen here anytime soon, what are other states doing, to combat that problem? And what are the new proposed rules and changes that are, being reviewed now today at the top with ONC and others? How does that impact what Teresa does every day in her network? How does that impact John and their network? So we're going to get into a dialogue. We're going to try to keep it open. If you have comments you want to share, we're going to try to allow enough time for that as well. So some of the areas that we're going to touch on, everyone knows what an MPI is, right? A master patient index software, pretty much? Okay. How many people today in their health organization, if you're a hospital or a physician-based organization, an ACO, a payer, actually have an MPI running today? Just a show of hands. Okay. You guys too? So we're going to touch on some of the newer technologies that are out there today and what's happening around the patient matching algorithms. They're a lot different than they used to be 20, 30 years ago. Data standardization is becoming much more of a focus, looking at things like address normalization. How do you ensure that you have enough data on your attributes? And what do you do if you don't? What type of services are out there that provides that value to help you get that information and bring it into your sources? And then what do you do from a data stewardship management perspective? I mean, everybody's looking at reducing footprint and resources, doing it more economically but reliably. So again, I think we've got three interesting perspectives up here, and we're going to try to address each one of those through some questions that we've put together. And again, we'd like to hear from you as well. So if you're doing something in your network or your health system that you feel is relevant and want to share, this is what we want to do today, is keep that open. So Teresa, why don't you just a little bit about your network, what MiHIN is all about, some of the key things that you have focused right now.
Yeah, absolutely. Am I on? Maybe not.
Push it up. There you go.
How's that? Oh, good. Thank you for inviting me. It's great to hear what other states are doing, and it's just exciting to share ideas, and because that's how we all get better across the nation. Utah, while we have 3.2 million citizens, actually have over 6 million patients in our MPI. We are a destination, so we have people from across the world coming to our Moab Canyonland and our Canyonlands, and having an accident on the Jeep Trail. And so they are in our MPI, and we have their clinical information. So while we have that many patients with clinical data, we really value those notifications and ADT alerts that we just heard about. And in fact, so much, we send over 600,000 a month to primary care and to case managers, because we believe the stakeholders, payers, providers, all need this care, and we're hoping to expand it to patients and their caregivers at some point. So Utah has really been focused on our statewide HIE. We connect a lot of large health systems. We're fortunate to have some of the best health systems, I believe, in the nation in Utah. And we're challenged because they chose different EHR vendors. And so interoperability is key. One of those that I missed because I was on a conference call, initiatives that we are looking at is social determinants of health. And even in that arena, they chose different systems. So data interoperability is so key. We are a standards development organization. It started 26 years ago to work on standards, so we believe in standards. We are a clearinghouse. That's where we started actually exchanging administrative transactions. And we celebrate 10 years in the HIE business this year. So happy to be here.
Great. So I'm going to ask you a question, then we'll go over to John. So with all the recent proposed changes that are going on today around interoperability standards and policies and patient matching being part of that, how does this help you both short-term and long-term? What do you see the impact being for MiHIN based on your model?
We believe that we need to assist our full community, our whole community, in helping with better identity management. I actually did read the ONC 700 pages. I think I enlarged mine a little bit. And one note I wanted to make, and I wrote it down so I'd get it right. Per the College of Healthcare Information Management Executives, 1 in 5 providers named lack of appropriate patient matching as the primary reason for inadvertent illness and injury. 1 in 5. That is huge. Patient safety is so important for us in our healthcare community. And whatever we can do to pull these identities together and be able to share that with our community is of utmost importance. We are very similar to MiHIN in that respect, and we have an initiative called This Is You, that provides identity management and provides those disparate MRNs, IDs, to our community so that they can help identify that this Teresa at Dr. Smith's office is the same as this Teresa over at the Intermountain Healthcare.
Good. John. John is with New Jersey Institute of Technology. So John, a little bit about your vision and mission there at NJIT.
So the New Jersey Innovation Institute, we actually run the New Jersey Health Information Network for the State Department of Health, who's the actual owner of it. It was at the same conference last year that we had talked about, we had a new commissioner coming in and really turned the tables. He made it mandatory that people participate in the HIN, mostly by getting out there and talking. So the Health Information Network at the time, we had just finished an ONC pilot project, which had just been turned down, and we were looking with the Department of Health, the new commissioner coming in, and he gave us the mandate, get all the hospitals engaged in the next year. We got there, okay? That was the end of May. We do have every single, except for one, I'm sorry, legally onboarded to the Health Information Network. Are they all connected on that yet? No, but they will be by the end of June. We also got a nice little bonus from our commissioner that if they don't get onboarded by the end of June, they lose charity care. So the sticks and levers, they do work. So over the last year and a half, we have gone from having a couple pilot sites to having virtually every hospital onboarded and starting to exchange data meaningfully in the state for the first time in the state's history. So that's really the high-level overview of what we're doing. The organization itself is we are part of the New Jersey Institute of Technology, the state's technology university. We were one of the original high-tech recs, and we graduated to do practice transformation. We do a lot of measures work. We are CMS registry, as well as we do a lot of value-based care.
So question for you then. Can you hear me? Good. So why do patient matching and consent management requirements go hand in hand as a critical business process to support these new services such as behavioral health, PDMP, social determinants?
Well, if you were here yesterday or here today, you heard a lot of things about substance abuse, behavioral health, sharing data, consent management. If you can't be sure that someone is who they say they are, how can you do any of that? If you are doing something as simple as admission, discharge, transfer notifications, and you can't identify that person and get that to the right care team, you're missing the boat right out of the gate. And if you take it even further, talking about patient consent, the only way you're going to get patient consent is if you get it down to the patient, get consumer engagement. One of the things that we're working on is an application called MiCave, which loosely translated is My Key. What that does is it allows a consumer to actually download an app that we're publishing, allows them to identify themselves, prove who they are, and it allows them to build a care team. So with that, they can then share documents with their care team, they can give consent, they can revoke consent, and it's all on their mobile device. So we're trying to simplify it, and really it's a pilot program. And while we're using it for basic medical pieces, we're also using it in some of our community efforts. We run pop-up clinics in local food banks and high schools where every time they come into the food bank, they're given a clipboard of papers. It's the same thing they fill out every time they come to the food pantry. If we can now electronically store those and save them for those folks, it just saves time, saves workflow. You can also do some of the public health reporting through that, as well as some of the social determinant surveys. So it really gives us a consumer-focused point to start, and identifying them, you can't do any of that. If you talk about delivering a pregnancy risk or any other risk score about a patient, you have to make sure it's definitely that patient. You do not want to be sending an indicator that someone has had Narcan in the street or has received opioid prescriptions if it's not the right person. So that's why identity is important to us.
Great. So James Nolan is with MiHIN. So a little profile of, I mean, most people in this room know MiHIN, so we don't probably have to go in a lot of detail, but kind of share a little bit about some of the initiatives.
Yeah, absolutely. So MiHIN, it was established as the state's designated entity for health information exchange. To date, we're connected to over 130 organizations that are sending us ADT notifications on a regular basis. We're right around 6 million ADTs outbound to the organizations that we have receiving from us. Those are physicians' organizations, providers, the payers in the state of Michigan. And with all of that data exchange comes the biggest challenge. It's identifying who that person is and then identifying who cares about that person. So we've sort of managed that challenge of identifying who cares about that person through the active care relationship service and our relationship management platform. But it really does come down to understanding that the records that we're getting from, or that we can get from the organizations that are interested in receiving data, like the payers and the POs, don't always store information in the same way that the hospitals store their information. And even within organizations like the health systems and hospitals that we're receiving data from, they don't always store information the same way about the same patient every time, depending on which registration clerk is taking the information at which time, depending on when that information was captured. With that, you have this issue where there sort of becomes two ways to look at patient matching as a whole. It's looking at it from internal to an organization and sort of reconciling all of the records that you have all the clinical information that you have about a patient and understanding what clinical information should be attributed to what patient. And then you have this separate issue that is related, but has its own challenges around moving that data from one organization to another. And we're on the stage, we're all part of health information networks, are all supporting that type of data exchange throughout our states and our regions. And that comes with its own challenges. There's mitigating the discrepancies that exist between disparate systems is sort of the number one issue that we face on a regular basis, trying to really get the information to the place where it should be delivered to. It sounds like an easy solution to solve, but it's really not. I think John talking about bringing some of that to the consumer is something that we've considered, and I think something that has a lot of merit when you're thinking about who knows the most about a person's demographic information, who knows their name, their current address, what their date of birth is. The person does. So when we're thinking about trying to identify what demographics to use, that's a good place to start. And if there are avenues in place for us to do that, Teresa, you talked a little bit about the national proposed rules and things like that. The focus on patient-centered access or patient access, I think that's going to open up a lot of opportunities for really capturing that information at the source. And then it's about disseminating that information throughout the network. So I think one of the things that we're sort of most interested in is how do we sort of democratize some of the patient matching challenges across all of the organizations that we're connected to. And I think that's sort of been the focus that we've had with MiHIN so far.
So let's elaborate on that a little bit. You've always been, MiHIN is kind of the forerunner in developing, latest technologies to solve these complex problems. Let's talk a little bit about FHIR. What do you feel are some of the advantages of using FHIR to help move that data across these networks?
So I want to be a little bit careful around FHIR. I think when everybody has an opinion and on FHIR as a standard, and I don't have any thoughts to the contrary. I think it's in current state the sort of where things are going in terms of sharing information and becoming a little bit more aggressive about sharing the right information when we talk about what is right, the information at the point of care that's most important at that moment in time. But at the end of the day, and I'm gonna quote someone that I heard at another conference talking about the same sort of challenge. I wish I could remember her name, but at this moment I can't. FHIR is a data standard, right? It's a data transport mechanism. It isn't a magic bullet for patient matching. It doesn't solve the issue of having to know who a person is, and for all of the organizations that are participating in that data exchange to understand that they're talking about the same person, whether we're talking about in the consent framework that John was mentioning, or in just sort of standard data exchange between two organizations. You still have to know who the patient is that we're talking about and have everyone in that sort of chain of trust and sort of data exchange framework understand that this is the person that we're talking about. And that can still be difficult. In a query-based exchange model, it's sort of even more important to know that the person you're requesting information from my system is the person that you think they are and that I think they are, so that we can deliver the right information. We're not stepping into or crossing any boundaries in terms of what data we should and should not be sharing.
Okay. So Teresa, going back to you, you guys are doing a lot of exciting things at MiHIN, and we've talked about some of the newer technologies around MPI and data standardization and bringing in additional data to help fill in where data is missing. Can you kind of share with us maybe a couple of the areas around your HIE and maybe the claims data area that you're doing where you're really measuring the success of making sure patient matching is in place before you actually start sharing that data across your state lines?
Yes, happy to. So we do believe the more data you have, the better patient matching you can do. And so the more information and demographics you have, the better. And so I don't know about you all, but in Reference Lab, tends to be the worst in patient matching. And it's because those poor reference labs usually don't have a lot of data. They don't get to see the patient. A lot of times there's a sample sent and just brief information. And so as you're trying to pull that together to the correct patient, being able to have as much data as possible really helps. And guess what you have with reference labs? Payer data. You have a claim. Typically, those are insured data. And by having that additional piece of data, the insurance ID, plus the name, plus the address, allows us to do a better matching. So clearly, the more data we have, the better. We have actually been looking at doing a pilot with the Utah Population Database, which is more of a historical database. It is Utah, and you know we do family history. But it is a huge database of identities that also talk about relationships. And as we start working in the pediatric area, and I was excited to see some work by ONC in the pediatric area, the children are a difficult one to make sure you've got the right identity because they don't have a lot of referential data that we can go back and check. They don't have a mortgage, they don't have a driver's license, they don't even have an Apple phone, most of them don't. But then, in addition, there's usually particular consent that follows them. And so, especially with our interesting world of divorces and step-parents, there's all sorts of consent that is involved in allowing for that information to pass. And it will be great to have that consent be able to follow. So one of the things we are working on is children and youth with special health care needs and understanding if our university medical center has already collected that information and knows the parent, knows the relationship, and knows the appropriate consent, can that be brought across? And can it be brought across with a fire standard? So we'll let you know how it goes.
Very interesting. John, let's go back to you. You've in the past had some challenges with your MPI. There's been a change of the platform. What are you seeing today as some of the most significant gains? Maybe you can share with the audience around not only the engine, but other things that you're doing, to really put patient matching much more forward and centered, around the different initiatives that are going on.
So we should probably start off with a little bit of the environment. Today, we have 8 HIEs in the state. We have a handful of hospitals directly connected and several large healthcare systems, all running their own MPIs. And none of them are good, and they would all pretty much generally admit that. It's not something anyone's proud of, but it's the fact. We also have Department of Human Services, which actually owned the previous statewide MPI, and Department of Health that are two different departments. Then due to the legislative requirements of public health registries, it developed into, okay, so we had a state MPI, but as it was deployed out to all the public health registries, it was actually little silos of data. They didn't share data between them, they didn't match in it, so we just had a whole slew of that. As we looked at the marketplace, picked a product, and started deploying, one of the key things was the ability to manage those data sets, to be able to consolidate them, but put the controls, the rules, and the security around them to make sure that the public health registries could share data, but only where appropriate. You don't want a data steward in an immunization registry being able to look at communicable diseases. It's not allowed. So we have the ability, the flexibility to still see that there's data there, but not see the source of the data to be able to look at the data, which really does help the next piece, which is the historical data that Teresa was just talking about. You have a patient that you're trying to match. People are transient. They'll be in an inner city. They'll have 3 different apartments. And if you only have one data set from your data and it's wrong, you're not going to be able to match it. But if you start to see, well, this person actually did live at this location and this location, so hey, these 3 people might have previously been a not merge, this is definitely the same person. So it's by adding that, and then even, say, normalizing data is huge. The addresses, clean up things, and all the other logic behind it. Then the other big piece that really, I think, is really helping is the ability to use a real-time API. Previously, it was a batch mode. You had to go into the tool, and then you had to actually go back to the source system and make the same change. which is just not sustainable, and that's one of the reasons all these public health registries' data isn't very good. Even the ones that they spend a lot of time and money trying to clean up were still not very clean. So by able to integrating real time in the workflow, the first one that we went with immunization, they can actually, within their own workflow, identify a patient, do the merge right there, without having to go to another screen, another system, log in, log out. Those are some of the biggest things that really helped us, and just the individual scoring and the public health registries not all having the same data elements. Immunization, you might have birth order, plurality. You don't get that with communicable disease, and then trying to match across those different data sets is just a challenge.
Interesting. James, let's go back to you. So MiHIN refers to common key service. So I'd like a little bit of perspective here. When you take common key with, an MPI matching engine, what do you gain from that? What happens if you're moving that data, as you would call in transit? How does common key and the MPI actually help reconcile both of those use cases?
Yeah. So it sort of ties back a little bit to the challenges that sort of from the health information network level or the HIE level, trying to solve that problem of being able to quickly identify who a patient is and sort of accurately link them to the organization that we need to deliver that information to, right? So in addition to that, we're also talking about in the MPI that we have today, we're looking at over 9 million identities, and we're constantly processing records through that MPI, through the active care relationship service, and through the ADTs that we're receiving and delivering as part of that common key service process. So there's a lot of, there has a potential for sort of a lot of data stewardship there when you're talking about all of the disparate sources that we're connecting together. What the common key service does for us is really allows us to take advantage of all of the probabilistic matching, all of the sort of the next generation technology offered through an MPI in terms of matching, and apply it to that in-transit sort of process. And it also allows us to sort of take the patient matching process and push a lot of the responsibility or share a lot of that responsibility for patient matching or patient identity management out to all of the organizations we're connected to as well. So by sort of sharing, Teresa and John both said that the idea, so the best way to improve patient matching is to have as much data as possible. We took that maybe one step further and decided to add an additional attribute to that, and really sort of harp on that idea that having additional information that's common across all of the data sets that you're connected to really sort of simplifies that matching process a little bit and allows us all to be on the same playing field, while also allowing us to all help each other improve our own internal data quality, because there are feedback mechanisms built into that process that allows one organization to say, hey, the information we had on this patient was that they lived at this address and this was the spelling of their last name, but we got an update now and that's not their address anymore, and this is actually their address. And it turns out we had 2 records for the same patient in our system that we've merged. Here's that information. Can you communicate that out to all the other organizations that are participating? So now we've really taken data stewardship that's happening at one organization and sort of pushed all of that information out to all the other organizations that are participating, so that they can sort of use that in their own data cleanup efforts. So it's really twofold. I think at the end of the day, the more information that you have available for the patient, the more you can add to your understanding about who a patient is, and the more that's commonly known and commonly understood across all of the organizations that are sharing data across the network, is the sort of cornerstone for data exchange, or effective data exchange.
I'm going to go back to Teresa. So maybe share with the group here within MiHIN, what have you put in place, as we're waiting for policies and standards to come together, maybe around some of your own data governance policies. What is working for you today to measure the success, hold yourselves accountable around both patient matching and this real-time interoperability? I'm curious to have you share, what are you guys doing today to actually manage that and hold yourselves accountable to that?
Well, we're never satisfied. So we're constantly looking at new technology and new methods to improve our patient matching. So that's one of the pieces. We're constantly measuring and trying to test ourselves. And just as James has said, it is important, the HIE brings all these disparate sources together, and we're trying to do this matching. But the more that we can make the edge more accurate, the more accurate we will be. And so especially our providers that have vulnerable populations that maybe English is a second language, or they have unique naming conventions and unique birthday assignments, it makes it very challenging as we're trying to identify one person as they move through the healthcare system. So the more we can do to educate our community and to continually improve them and what they're doing, the better for the HIE itself.
Good. John, same question. If you can share one of your, key successes around patient matching and interoperability and some of your own data governance policies.
One of the biggest challenges we had is, I think we've kind of already touched on it, is the lack of a consistent demographic selection for the state. We finally, just recently, kind of got an agreement from the state to actually publish not a legislation or anything like that, but a recommendation of these are the data elements. And to us, that is a huge uptick because there's been nothing. There's been a smattering of different data sets. We collect social, we collect the last 4. We don't collect date of birth for this registry or whatever it is, but to at least have a basic set of demographics that can be standardized. To us, that's probably the biggest hurdle that we've overcome this year.
James, similar question. I mean, you talk about Common Key and you're making this now available to other organizations. How is that working? What's the adoption been like, and how is that actually supporting kind of your policies for sharing and using that same information and making it more available but also successful in that matching process?
Yeah, so there we go. We've had over 40 organizations that are participating sort of on the sending side, who are sending their ADT feeds or including Common Keys in their inbound ADT feeds to MiHIN. We have a number of organizations that we've onboarded on the receiving side that are receiving those Common Keys back on their ACRES files. But like any sort of common identifier, the more organizations that are participating in the service, the more effective the service will be. Again, harkening back to sort of the conversations we've been having about having that additional data and making that additional data available, creating sort of a stronger network that data stewardship can be sort of a shared burden across all of the organizations, pushing more effective information, more accurate information out to as many folks on our edges as we possibly can. I think we've seen a significant amount of increase in the number of outbound messages from us that we're receiving when we're using the Common Key for matching. A lot of that has to do with the fact that we might have had 1 or 2 organizations that had a shared patient, but they were storing their demographics in different ways. So when we get those reported to us, we're looking at them not as 2 separate people, but as the same person. With my name's an easy one. My name's James, but depending on who I'm talking to, I could be Jim, Jimmy, Jamie. Like there's any number of ways that my name can be captured. And I'm also really terrible at updating my address with organizations that should have that information on a regular basis. So I am part of the problem. But if with the sort of introduction of what we've done on the Common Key Service side, we're able to find those relationships regardless of whether or not the demographics are stored the same, either in the inbound message or in the records that we're matching to deliver that message outbound from us. The other thing that I think we're most looking forward to as we talk about, we think about all the conversations we've had around TEFCA and moving forward into that space. The challenges that we've talked about so far from a interoperability perspective and from a data sharing perspective only become more complicated the more organizations you're talking about connecting to each other. So Chic has the patient-centered data home. There are some challenges that exist around sharing data between those organizations. We'll have several QHINs as TEFCA move forward. Sort of understanding how best to share information across those organizations is going to be a challenge, but it's not a challenge that I don't think there's a solution to. And I think from our perspective, the adding the common key or adding that additional attribute is one of those solutions. I think there's several things that have to work in concert with one another in order for us to really have a solution that meets the needs of all organizations that are going to be participating in that type of exchange.
Interesting. So Teresa, you're involved in some of the national initiatives, Chic being one of them. Data standards, being that we lack them at the national level, how do we make this happen today? How do we not have to wait until there's agreed upon standards in place? What do we need to do? What should the focus be?
Well, so a couple of thoughts. And first off, it comes from what John said. We all have to agree on some key data elements, and we're starting to see that come out of the US CDI, and so those are good. What is interesting, and ONC can take credit for this, is the information blocking has actually spurred our providers to say, can you give us a report card of where we're not meeting the data standards? And let's not be hidden on who isn't meeting, let's be fully transparent. So the 50-some hospitals that are in Utah tell us who is giving what data and who's missing data. And let's try to come as a community and become more standardized. So, I'm thankful for the little bit of push to some of our organizations for them to step forward and say, we're going to get in front of this. We're not going to wait for someone to complain. We need to standardize. We need to standardize now. So I think that's helpful. I will also comment on what James said on PCDH. The patient-centered data home, when we connect to each other, we do a matching too, so that I have his common key. And yes, I looked in my data, and we have almost 600 Michigan folks in our MPI. And so as they're having services, we're able to match, and I can share our common key, which I love that term, with your common key.
You want to elaborate on that a little bit?
Yeah, I did, just because I think I can maybe expand upon a little bit of the FHIR conversation we were having earlier. So I think that there's an opportunity for FHIR to have a big impact on patient matching as a whole, establishing the patient resource that as a standard for communicating who we're talking about between organizations is a huge opportunity for us to maybe establish something that we can all agree is required for that type of exchange.
John, do you have any further thoughts on that one?
I was going to say exactly what you just said, so.
Okay.
But then they also, the fact that they identified the code sets, I think is so valuable to us, where on the claim side, I will tell you, sometimes the gender comes in very different flavors, but it's lovely to start seeing some of that standardization on the code sets.
Are any of you guys finding any other data attributes, and we'll talk like cell phones, email addresses, multiple addresses, are you finding those to be helpful in the matching process?
Absolutely. We use cell phone, last 4 digits of the Social Security number, although our state has asked providers not to gather it and change their insurance ID away from it. But that still seems to be very helpful. Email address less, but it's amazing how many payers will ask us for the demographics back because their case manager can't get a hold of the patient, and so they're looking for the latest telephone number in our demographics.
Yeah, I think that's the same for us. I think we're not going to turn away any demographics that any organizations want to make available to us, because the more data we have to match on, the better matches we can make in terms of what we have available to us in the MPI, but also what we're doing as part of the Common Key Service. I can't help but make this comment. It is funny about the last 4 episodes, because that's something that MiHIN and that we utilize for our matching. And sort of the national identifier comment, Greg, that you made earlier, and it's always been funny to me that we sort of have this national identifier that we're assigned at birth, but it's this sort of thing that you can't touch with a 10-foot pole in terms of utilizing it on a more regular basis. If there was some policy levers around just adopting and utilizing something that's already pervasive across the country, that might be an option there for a national identifier. But until that's the case, we're interested in collecting as much information as is relevant for patient matching purposes.
Although that's not perfect, because I'm sure we found different people having the same Social Security number.
Yeah, that's fair.
Another. So we just have a couple minutes left, and wanted just to open up and see if there are any questions that you guys have that are top of mind, pressing for these 3 networks. Any questions? Got a question over here?
Thank you. So a couple of questions, I think, for some points that Teresa raised, just in terms of not using email address. I'm just curious why you don't use email address to match patients. Second question has to do with the report card that you were talking about in Utah. Is that a framework that other states are interested in adopting, or is it something that you've talked about publicly with SHEIC and other organizations?
We would use email address if it was there. It would be a piece, but it wouldn't be the full piece because, for example, my husband and I share the same email address. So you do have to watch that. Actually, I can't take credit for the report card. I stole it from the New York HIE. So definitely it would be a SHEIC thing that we should all embrace at SHEIC.
And we do see that things like email and phone number are inconsistent. Some organizations have them, some don't. But we're seeing more and more emails, and email seems to be even more consistent than address these days.
No, we're at the end, but any other questions?
Yeah, Linnell James, Blue Cross Blue Shield Association. One of the emails that came across today was that a letter went to 4 folks in Congress and Senate asking them to provide some relief, regulatory relief for inability for federal funds to go for a look at patient matching. Are any of you part of that effort, aware of that effort, think it'll have any success? I believe there were at least 10 major organizations, including the association and several provider organizations that co-signed that letter that went out this week.
Well, MiHIN did not write that letter, although we'd be in support of it. We were and wrote in our comments to ONC, we're very much in support on study on this subject. I'm not sure that there is a common ID that we can use nationwide that will suffice, although we do have a Social Security number, but it is an issue. And as we start trying to use FHIR and trying to do this query exchange that we talked about earlier today, we need to have the patient ID to get the correct patient.
Yeah, I think MiHIN would also be in support of I think, looking at ways to establish that identifier, or at least the research involved in sort of understanding how and what impacts that could have on patient matching as a whole. If the end result isn't a national identifier, there are still going to be things that we can glean from that type of research that would help us improve patient matching. And as Teresa, you talked about 1 in 5, that's a huge statistic that we need to address in some way or another.
Right, and there's, of course, always room for improvement, but I don't think we should be waiting for anything, right? There's been enough over the years.
Good point.
There's been enough research on what the demographics are for doing patient matching, and we had a national identifier. Social Security was used all over the place. My college ID had my Social Security number printed on it. So I mean, we did have it. We don't have it anymore. So let's go and let's look at what's possible. But what can we do today? Because we can't wait.
I know we're at the end of our time, so any other questions?
Yeah, I'm curious, what sort of duplicate rates do we see in hospitals today? Like, how do we quantify the problem in terms of where we're at and sort of where we want to go?
Good question. So what we are finding, and we have actually started our own campaign, a lot of people don't know that number. They think they have 2%, they think it may be 1%, but they really don't know. So one of the things that we've started as a company is we actually go out and do an assessment, and we actually look at the data for them. And we run it through our master patient index. We actually come back not only with the duplication score, but we're able to actually drill down into the data and actually see what's causing the duplicates. We've talked to health systems where the HIM director thinks they're around 3 or 4%, and we come back and they're actually closer to 10 or 12%. So again, it's what you don't know is what hurts you. And so we feel, and again, it's something we're trying to do before you even say replace what you have. You're doing it wrong. Let's find out what the problem is and where the problem resides. And I think if we start doing that and holding ourselves accountable and doing that, we call it the checkup. You might have seen the postcard on the table. Really, if you don't know your duplication rate, you really should. And you need to talk to your current vendor or talk to a new vendor and say, look, we need help identifying if we really do have a problem. And if we do, what's causing the problem and what should our roadmap for success be around patient matching? So highly, highly encourage you to do that if you don't know that number. Because, I mean, we've seen duplication rates, and Teresa mentioned the lab, they're the worst. We have clients that are labs that have over 20% duplication rate in their data, and they know it. And they continue to create more duplicates because they don't actually have the time to resolve that when that requisition's coming in. So they go ahead, create a new patient, and they even create more of a problem. So, all right, thank you very much. I think we're at the end. We appreciate, thank you for the panelists up here.